So I would like to welcome on stage our first panel on inclusion in health, gender and disabilities integration. And I would like to welcome Sarah Minkara, Special Advisor for International Disability Rights for the US Department of State. Welcome. Sure. Jody Hirtner, who is a women's personal protective equipment specialist, inclusive standards advocate, and founder of HelgaWare. Jody, welcome. Yana Andronopoulou, enterprise lead for Microsoft Greece, Cyprus, and Malta, and executive sponsor for Women at Microsoft. Welcome, Yana. And last but not least, Nefelis Tournara, PhD sociologist and research analyst at Mindview. Welcome, Nefeli. Can you hear me? Oh, great. Yeah, that's better. Great. So I would like to start with Sarah, and welcome. In all the issues, you have the microphone in front of you, so yeah, it's great. Yeah, don't worry. So in all the issues we try to touch upon at the Inclusivity Lounge, we try to include as many aspects of diversity as possible. So we are really grateful to have you here. And I would like you to ask from you to share some of your perspectives as a Muslim woman with a disability living in a Western country, the US. And I know not all Western countries face the same challenges and the same problems around inclusion in health. But I would be very grateful if you could share some of your perspectives and experiences that you try to bring in your work as a special advisor for the US Department of State.
Amazing. Thank you so much. Can you guys hear me?
Yeah.
Yes. Sure. Okay, great. Amazing. Thank you so much, Stella. I just want to thank first our amazing U.S. ambassador. Thank you, George. I really appreciate your kind words, and our embassy team, and of course my partner in crime, Hannah, who's somewhere there, and to our panelists. So I'm going to answer your question in a few different ways. One, I'm going to say something, and I want you guys to really, really think about what I'm saying right now. People who are not counted do not count. Okay? People who are not counted do not count. Now let's take that to the disability community. In most spaces, in most programs, in most services, in most systems that we are in, we're not counted. And I will start off with, and I know the statistics, and you've probably heard the statistics, that 15 to 16% of the world's population are persons with disabilities. You know, and let's take that half of that are women with disabilities. 1.3 billion individuals in this world with disabilities. We are people with so many different identities. And that statistics is barely brought forward or realized or actualized or seen in our programs and services. And this is where I say data really matters. And that's the starting point, because what does data do? It illustrates the story of the reality. But people do not see us. And if they do see us, they see us from a medical model, just connecting it to the topic at hand. We need to move disability from a medical model to a social model. Most countries have signed or ratified the UN Convention on the Rights of Persons with Disabilities, right? Which requires countries to collect data and use data to inform policies. But in traveling all the world, I go and I talk to different ministries and ask them, oh, how many persons with disabilities are in your country? I hear 3%. We're so proud. I'm like, I don't think you should be proud. And first of all, are you proud because it's a small number? Are you saying disability is not a good identity? Or are you proud because you're actually not collecting the true numbers? What are you proud? We need to make sure that first we require governments to collect data through using, for instance, the Washington Group, which has been recognized as the most effective ways of collecting data on disability. That's number one. That will illustrate the true story of persons with disability. We need to also be collecting data on research when it comes, for instance, healthcare. Are we actually applying healthcare research on persons with disabilities? A lot of times they're left out. I'll give you an example. Strokes, patients with disabilities are not really brought into this research conversation. What does that lead to? Outcomes and results do not apply on persons with disabilities. We need to make sure also our implementing partners, our programs, for instance, when we're responding to a crisis and we're putting forward refugee responses, that we actually collect this aggregate data on disability and be able to provide services, because you know what, when they're not, we are left out, and we're always left out. Data really tells the full story. I've been so many countries where I meet with women's rights organizations that are working on domestic violence efforts, pro-democracy movement organization, all these, and I ask them, are you integrating disability? A lot of times they're like, I've never thought about it. Yeah. These are the movements and the organizations that need to be thinking about it. So I want us to first be asking and holding our spaces, our systems, our governments and corporations to have data on disability, use the right comprehensive data, tell the right story, bring forward the full picture, and then demand that disability is integrated. Thank you so much.
Thank you so much for this. Thank you so much for this perspective and this introduction. And I think it's important to stay on the issue of data because it's what you said at the beginning is so important. Can you please repeat the phrase? People who don't get counted.
People who are not counted do not count.
Great. Let's all of us remember that. Thank you. So I would like to turn to Jana. And because we have talked in the past about how technology can help, can support this effort towards greater inclusion, not just in health, but because this is a lounge dedicated on health, let's focus on that. And we associate data collection with technology. So I would like you to speak about what Microsoft, what the technology company can do for accessibility and inclusion and equity in health, and how.
Okay, hello from my side. We in Microsoft, we are not the experts in health systems, but we are experts in providing tech that can make the health systems more accessible. Actually, technology today can support accessibility for all the stakeholders of a health system. So health employees, patients, research institutes, also health services delivery. Let me give you some examples, starting from some basic examples, and then I will move to the value of data, because I fully agree with the statement. For example, regarding the health employees, okay, we can have today very inclusive hiring process, leveraging technology. What we do, for example, in Microsoft, we do have an inclusive hiring portal where people with disabilities can get frequently asked questions, and they see, you know, how they can be more prepared for, let's say, the position discussion as candidates. They can also have a disability interview access request form where they can fill in their specific needs, and we can take care during the interview process, so to have assistive technologies like, for example, screen readers, like Braille keyboards, putting bigger breaks between the interviews. And then we have a fully accessible onboarding for those employees. And while they are at work, they have all the means, even, let's say, building orientation services, assistive technologies, mentors to help them to thrive equally within the workplace, which is very, very important. Now, if we move to the patient's engagement, what we see is that now with technology, we have the capabilities for completely personalized engagement with patients. So by exploiting data and by designing inclusive applications, we can have, for example, applications with that everybody, even you have disabilities or you don't, you can have access, for example, to your health data, you can book your doctor appointments, or you can actually use other data and services in the health sector. Now, if we move to the very important statement about data, and I fully agree, I think today we are in the unique position that we have the capability to process almost a limited number of data thanks to the technology we have at hand. And this is very important because we can analyze data and even anonymize data for all segments of the population. And this is very important because we can resolve problems for everybody. And this can make the health system truly inclusive. And that's why I fully agree. Data is number one, that, it's the first step that we need to take, the collection of quality data in order for us to be aware and act upon it.
Thank you so much. So if data is number one, and I know, Sarah, that you spoke yesterday on a panel about inclusive education, am I right about that? So we have the data, and we are talking about inclusion in healthcare, but we mostly talk, if you have a picture in your head, then I guess it's almost exclusively about adults. Adults in healthcare, maybe senior citizens in healthcare, adult workers in healthcare. And I wonder how education from an early age comes into play as a second step to create a more equitable and inclusive health sector for the future.
I mean, education is, the seventh stone to creating our future economies, our future systems, future healthcare. And when we achieve inclusive education, when I mean inclusive education, that means we're creating a space, a curriculum, an infrastructure that is inclusive for persons and kids with and without disabilities together, right? When we achieve inclusive education and we're integrating disability into the curriculum, so it's mainstreamed, we actually create a system where kids with and without disability learn and play together. And we have teachers know how to bring forward universal design, universal teaching and learning. And you also have all of this, you're creating the first culture of that inclusion and accessibility. Universal design is the norm, is the expected, is the reality instead of an atom. Because you go into healthcare right now, a lot of healthcare systems are not accessible for persons with disabilities. They're not. Whether it's the technology, whether it's the infrastructure, whether how doctors come and speak to you. I've had many cases where a doctor doesn't speak to me, speaks to the person next to me, as if I don't exist in the room. When you integrate inclusivity from an early stage, then these kids will be the future where they actually demand the inclusion of everyone across all sectors, including the health sectors, without seeing it as a different, but an add-on. But I would also say, but see it from a point of value. Because when you do create a healthcare that's accessible for persons with disability, it's going to be a value for everyone. And by the way, I'm going to say a last point. Disability community is the most inclusive community. Why? Because any of you who doesn't have a disability, we call you guys temporarily abled. I'm just saying, any of you guys can have a disability at some point. So we're the most inclusive. Okay. That's not at the right.
Thank you. I find it very interesting that we have already moved from the patient side, to from the client side, say, the beneficiary side, to the worker side. And I want to ask Nefelis Tournara, who has done wonderful research on a very specific, but then not again so specific segment of workers in the healthcare industry. Nefeli has studied cleaners in hospital with a migrant background. And can I read a quote from your summary of the research? Great. So Nefeli writes, cleaners are an invisible, gendered, and nationalized workforce that is exemplarily cheap, flexible, expandable, and easily replaceable. Recognizing the intersection of social categories of gender, class, and ethnicity illuminates the many reasons why working women face undervaluation. It is therefore imperative to explore how cleaners become subjects of value, gain credibility, and create spaces of resistance, challenging vulnerability, invisibility, and precariousness. Can you talk a little bit about what's behind this phrase? What hides, in the wonderful research that you have done that we should learn from? And, because inclusion comes with visibility. And can you talk a little bit about the invisibility of those workers?
Thank you so much, Stella. I think, yes, perfect. Yes, so my research is about those who are at the bottom end of the labor market. And it's not a generic category. It is gendered, it is ethnicized, it is raced, and it is classed. So we cannot talk about general experiences. When I did this work in order to complete my PhD, so when I was reading the literature, I came across this wonderful book written by Aguar and Herod. They are geographers, and they have done a very, very good research on care. But what do we mean about care? We mean they talk about those workers who are subcontracted, under subcontracted labor, and they do become invisible because their work is undervalued. So we have two things. First of all, it is the work, the nature of the work, the materiality of the work that is undervalued, symbolically stigmatized, and then we have the workers. The workers are gendered. We see women, men, and we see also the intersections between sexuality, and they are ethnicized, cheap migrant labor force, easily disposable, and of course they can release them at any time. What I have been reading the whole time was a lot of institutional analysis, how unfair the system is, but we did not know a lot about the migrant experience per se. That is why I took this chance and brought this into the context of Greece. Having women migrants coming in the 90s, working at the grey sector for many, many years, their care work has not been recognized. They had to move into the official workforce in order to secure a future for them, their husband, and their children. Most of them, since they have been doing domestic work into houses, the niche of care has absorbed them. So we see them at the hospitals. The majority are Albanian women and ethnic Greek Albanian women who work as cleaners in 2 public hospitals. Yes, indeed, as you clearly said, they become paradigmatic because they're easily disposable due to their gender and ethnicity. But having said all that, I want to say that they make their invisibility visibility. They take this as a working spirit and they claim back their respectability through their work, and how they claim back the symbolic, under symbolic terms. They transform, they create strategies, they collaborate with themselves, going against existential and working precarity. They use their ethnicity and civic status as a way to gain respectability, along with their femininity, working femininity. So we see them not being, under material terms, of course, they are victimized, but at the same time, this does not stay an obstacle to the resilient self, working day to day and aspire for a better future.
So, thank you for the introduction. I would like to ask you if we were to really include invisible workers, and not just cleaners, but also other kinds of carers in the healthcare industry, if we were to include them in strategy, in operations, in the way things function and are being designed in the healthcare industry, what would be the future of healthcare in Greece and beyond?
I love this question. Amazing. First of all, when we talk about invisibility, it's not something very abstract. We can say, yes, literally, it means when someone, you cannot see that someone. So I want to talk in very literal terms. So, first of all, cleaners, nurses, carers are three distinct categories, and they have a very antagonistic attitude between them. So if you go to the hospital and do observation as an anthropologist, for example, you could definitely see the different scales of it. So I will talk first of all about cleaners. What do we mean when we say invisible work? So a cleaner cleans, okay? She or he mops the floor, cleans a space, and they put, for example, a yellow, let's say, notification that this floor is mopped, is wet, please do not step on it. So they clean, and people come and step on the floor. People, visitors, doctors, nurses, carers, everyone, as if they do not exist, and then they still do it. This kind of invisibility, it really devalues not only their work, but who they are. So, in these terms, what do? They use strategies, they deconstruct their work, they increase their value. Another way of devaluating their work is when they speak to people, they do not address them, is when they devalue them, when they insult them, when they make racist comments, etc. So, nurses, different category. Nurses do not only do care work, they do organizing work. They actually inform the whole system. Their work also become invisible when their organizing work does not get recognized and only their care work is recognized. A lot of sociologists, anthropologists, and geographers talk about their body work, how difficult is their work every day-to-day life, and their emotional labor. Emotional labor is how they filter their emotions in order to keep up with the institutional protocol. So they have to filter themselves. Doctors do that pretty clearly, but they have the prestige of being the doctor. Nurses, they have to do the care work, so they filter all the emotions. But at the same time, their organizing work becomes invisible. And now we go to carers. Carers and unpaid carers, and that we will discuss later because it's a different chapter, also become invisible because their symbolic work also does not get recognized. So if we just give visibility and see all this work that has been done, then yes, we can actually completely transform the whole system from the beginning. This is me. And go against its rigidity. Yes, but it takes a lot of effort.
Yeah, we'll talk about that effort later.
Yeah.
I would like to move on to Jody, stay in the workers' realm, and ask you about the work you do as an advocate and as a PPE specialist and as a founder of Helgaware. How does this work intersect with the very active work that Nefeli has described, and what the issues are there?
Absolutely. So, as a young woman in engineering, I struggled on my outdoor remote site on the coast of British Columbia, Canada, in the rainforest. I struggled to find personal protective equipment that fit my body and worked for me. What doesn't fit doesn't protect. We know this. Yet all of the PPE available to me was made using men's body data. And for example, in textiles, menswear grading rules means proportionally, it just didn't fit for me. And then also, if I might speak bluntly, working in remote bear country, cougar country, there's limited access to the washroom. For a man to use the washroom wearing his safety coveralls, he unzips the bottom fly and he can go. For a woman, we must half undress. So that is not going to happen. So my job was impacted, my health and safety was impacted, because what did us women do? We don't drink. We don't go to the bathroom. We wait until hour 12 of a 15-hour shift before we start drinking water. And then if we have to go to the bathroom, we hold it. All right, you can relax. I'll stop talking about using the washroom. But that's just to give you an idea of things that we don't even consider. And the truth is that all personal protective equipment, you know, since COVID, we've now seen respirators, face shields, eyeglasses, gloves, big in healthcare. They've all been designed using men's body data, made to fit men's proportions. And what that does is it restricts our mobility, it restricts our dexterity, it impacts our ability to truly compete in areas where we're encouraging women to come, skilled trades, active STEM like engineering. We're saying, come into our industry, we want you here, we need you here. But once you get here, you realize your entire experience has been designed for men. It's very difficult.
So, Jody, is that a problem of data? Is that a problem of lack of women saying leadership position? What is this about?
Oh, how much time do we have? Well, so we do have women's body data, yes. We're not using that data. We have no legislation, no mandate to say, like from an engineering and design perspective, that if I'm designing a product intended for women to use, I should probably design it using women's body data and any gender-based known statistics that we have. And hey, bonus points, we should field test it on women too. But there's nothing to say that, no matter what the product is. So where it's most visible is where you're finding personal protective equipment, because that's supposed to be our last line of defense for injury. And if it doesn't fit, it just can't protect. Did I answer the question?
Yeah.
Okay.
I think you have. Thank you so much. Since we talked about professionals in the healthcare industry, I would like to move to the even more uncharted world of unpaid care. And Sarah, I wanted to ask you about the inclusion of disability in the care agenda. And to give you some context, the care agenda is an effort to prioritize the establishment and strengthening of support and care system for persons with disabilities. So what about what issues emerge from not including people with disabilities in the discussion around the care agenda, and how can we do this more effectively?
So, you know, we all experienced COVID, and COVID in so many ways shed light on the different gaps that we had in our system, including our care systems. On both the caregiving side and the care receiving side. And since COVID, there's been a lot of effort and movement, especially on the women's rights movement, of transforming and reforming the care economy and the care systems, which is really important. But where it could be very dangerous is that we don't include the disability community and perspective into these reforms. Because persons with disabilities, on one hand, when we do focus on making sure the caregivers are getting their rights, which they should, right? They need to be paid, they need to be respected, they need to be really valued. Sometimes, if the disability perspective is not put at the table, what ends up happening? Then the care receiving might be also hurt, right? We need to have both balance those perspectives and be brought forward and reforming in a more holistic and systemic way. And I also want to say, persons with disabilities can also be caregivers. Please, guys, don't ever forget that. We're not only care receivers. So this care agenda reform is so important for us to really make sure that people with disabilities are at the table. We need more of these organizations that are working on reforming their care economy to bring the disability community forward, again, from a value-based perspective. And when we do that, it's going to really benefit everyone. So thank you.
Thank you so much for your answer. Jana, a few years back, we talked with a colleague of yours, Antigoni Papanikolaou, about the bias of artificial intelligence, the prospective bias of artificial intelligence. And what Sarah talked about, nothing for us without us, nothing about it. Great. So how can we make sure that the artificial intelligence systems we create are being created taking into account the perspectives, the experiences, the data that come from underrepresented groups?
We currently live in a revolution, actually bigger than the invention of the internet, of the electricity, and actually AI will change completely the way we live, we interact with others, we work. The contribution of AI to the health sector will be immense. And of course, as our president said, you know, technology can be a tool and can be also a weapon. So we must make sure that we take some guidelines into account when designing AI systems to make sure that those are inclusive, to make sure that those are fair and treat everybody equally, to make sure that our data are protected, they are secure, to also make sure that those are transparent so human can understand the way that AI systems work. We, Microsoft, we do a lot of work on what we call a responsible AI, so to create platforms that enable equal access to people to innovate across industries. Particularly for healthcare, I think there are no limits on what we can do to create more inclusive systems leveraging AI. I have, for example, one of the issues that we have heard and I personally read is that especially people with disabilities need more time with their doctors, and overall patients declare that they need more time with the doctors. And I have been in US back in February, and we saw a case that during the examination of a doctor to a patient, AI was summarizing the whole interaction, so the doctor could have all the summary for his review and to store it in his files. And I was reading a report that was released last week from Medscape that was saying that the average physician takes approximately 19 hours per week in paperwork and administrative tasks, which is, so actually, you know, for me, sky is the limit on what we can imagine to increase, let's say, the personal interaction of doctors with patients and also with those of us that have some disabilities. And also, as far as we create the right principles and we learn, because this is something very new to all of us, so, you know, we keep learning, we experiment and we use it for good.
That's great, thank you. Yeah, sure.
Of how it's so important what you said, and I think making sure people that are designing the AI, you're also designing with including diverse perspective, including disability. But I'll show you guys one example of how AI can be biased towards disability, for instance. Right now, a lot of companies are using AI technology for hiring purposes, where the first initial interview is done through an AI. What ends up happening is a lot of times persons with disabilities get eliminated automatically because as a blind person, for instance, I'm not looking straight. I'm looking in a certain way. Or some people cannot, you know, the way we are interacting and behaving is not what the AI is seeing as norm. And that's limiting then persons with disability from the get-go. So when we're designing anything with AI, making sure that the design is bringing in the disability community and diverse, all kinds of communities to the table.
That's so important. Yeah, sure.
And very important, and that's why it's so important to have correct representation within the workforce. You know, every segment of the population in order to contribute, and also, for example, to what you mentioned before of collecting data. For example, in Microsoft, we have also a disability access desk, and we saw a big increase in using that during COVID. And actually, in this disability access desk, besides the fact that people can find information about accessibility, they can also place their asks. So actually, we collect a lot of feedback, and we assess. We take this very seriously. We assess it, and then, the one that can have positive impact, we integrate in our products. And this is very important. That's why I want to state.
That's so great. Thank you. Nefeli, if beyond tech and beyond AI, if we take what you talked about, vulnerability, invisibility, exclusion, and we take it a step further and we try to integrate this kind of thinking in the unpaid care sector. So how can we fight these ills and include unpaid care workers in the wider society, I would say, because then we are not just talking about the healthcare industry, we also talk about the wider society. So how can we do that? How can we become more inclusive of unpaid care workers?
Stella, this is one of the biggest problems of the welfare state. Silvia Federici has written an amazing book called The Caliban and the Witch. It is a feminist communist manifesto explaining how domestic workers, mainly women, offer care without being that counted as actual work. So it does not get remunerated. So firstly, economists, they still haven't invented a model that can assess, evaluate, what does it mean to care, which means to go home, to take care of the children, the elderly, clean, and all that kind of stuff. Because care is very an emotional aspect. So it is not very easy to actually evaluate it and then put it down into a remuneration. At the same time, this, of course, works on a gender basis. We see in many, many countries across the West and the whole planet that women have to stay at home to take care of the elderly, the children, and that means that if they're going to go to work, they need to work less hours, and this reflects on their pension later. So despite their educational background, they still need to do all this work that is unpaid. Let's talk about solutions, because this is something that, for example, I'm going to say two things just very quickly. Greece. Greece works a lot on social capital, which means since the welfare state cannot offer these kind of services, they count on the grandmothers, the grandfathers who take care of the children, or relatives. And COVID taught us that when we stayed at home, all of us, women got divided into working at the same time and doing domestic work at the same time.
Tell me about it.
Yes. So let's talk about collaboration here, because I do think that this is a matter of collaboration. Now we have a declining welfare state. We need to shift this. And there needs to be a cooperation between families and the welfare state. Otherwise, gender gap will maintain, and women still will do this whole unpaid work. And it is unfair because they do this flexible kind of work that does not guarantee them a full pension, and their work does not get recognized. Caring for the elderly and the children does not get recognized.
Yep. It's taken for granted, yeah.
Based on gender as well.
Yeah, mostly, yeah. Thank you. I have one last question for Jody, and then we could take some questions from the audience. When we first talked to invite you here to the Inclusivity Lounge, we weren't sure which panel would be the most appropriate for you to speak on. So you said, I want to speak on the panel that will have the most impact. Can you talk about that a little bit? What? No. That stayed with me, and I would like to learn more about the kind of impact you are hoping to have through your work as an advocate.
Thank you. Well, what I meant by that was we need inclusive standards. We need some sort of language and policy that comes right out of the gate and acknowledges women's bodies as distinct from an analytics and data point of view, so that when we move forward developing any product, whether it's pharmaceuticals, whether it's personal protective equipment, it is developed using the known data for women as well as men. It would be amazing to be able to even broaden that diversity to include other statistical groups that we have access to already. But for now, we're really only operating off of one. So even to get the word out there that we really need to start having the conversation about what does inclusive language look like in terms of setting standards and policy enforceable by law. That's what I was trying to ask.
Great, thank you so much. Before we move on to a question from the audience, any other call to actions that you people have and you want to share with our audience? Sarah? No. I was asking all of you, but because nobody else was ready to answer that.
My call to action is, one, you probably heard me a lot saying this, but anyways, first, ask the question, is disability accessibility part of your work? If not, why not? Two, and if it's not, I really want you to think, why not? Why is disability left behind? Third, I want you to really start intentionally, individually, and also systemically think about how disability accessibility can be a value to your own work as well. Those are my three call to action. Thank you.
Thank you. Any questions from you to our speakers, to any of our speakers? Yeah.
So, first of all, thank you. It's an amazing panel. I'm feeling the GM for research on Mata from Microsoft. So, first of all, I remarked that I'm so deep into this interview with AI stuff. I'm not sure how much we should do it more, etc. However, I have to say that we always have to compare that even if a person with disability goes in a physical interview, most of the time due to culture, he or she will be excluded. So the question is how we can use technology to make it even better. But my question goes to Nefeli. I would like to hear more about what are the proposed measures. I do believe that taking for granted is also a cultural thing. Scandinavians have a totally different philosophy of who does the job. I'm not there, we're not there, but I hope we get there. So the questions, however, for welfare, and what are the policies that the government should do in order to get there? We have a lot of discussion about what do we do with kindergarten at companies, even above a certain number of people. I'm not sure it's a solution. The question is how do we do it at scale? So I would like to hear what are the proposed measures.
And for your question, is it okay? Yes. I think one of the most complicated things in life is to create a fair welfare state. It's not very easy. We see people who have difficulty getting their pension. We see women having problem raising their children because they need to stay at home, but still they want to go to work. I think that, first of all, we need to do a better division of labor, of unpaid labor. So we have to deconstruct the whole gender stereotypical situation. Then the kindergarten, because as you say, it's not very easy to always say the state is going to cover this, the state is going to cover that, the state, because, okay, let's be frank, we need money for this. I mean, it's not very easy. I'm not naive, totally not. I think that it also has to do with the ethos of each institution to take responsibility for its workers. I think this could also help. Another thing is that I haven't said is that, and I need to address that because it needs to be said, Greek women were able to work because Albanian women came to their houses, cared for their children, cared for the elderly, did not get paid in the formal sector. So they still have so many years in Greece with not all their salary formally. And this created a problem in their integration because in order, for example, to buy a house, we need to prove that you are here.
Most of them didn't have the papers right. They were afraid of the papers. No.
I think it complements one another. That's why I think it's a very complicated discussion. Because domestic work, since we have not developed yet an economic model that can actually says, okay, clean the floor, it costs this. Care for the baby, costs this. And when it is subcontracted to someone who is gendered, ethnicized, raced, then it gets much more symbolically devalued. I'm sorry I haven't given you the answer. It is still something that problematizes me a lot, existentially and socially.
And I think we could speak about that for hours.
Yes, hours.
Yeah.
Still.
Thank you. Yeah. Yeah, sure. Yes, thank you.
You mentioned Scandinavia. I'm from Scandinavia, so and it is not so much better, to be frank. No. Basically, first of all, thanks for a great panel. I came a little late, but it was good comments. I'm coming back to the data side. I'm a banker, and we all work with numbers, right? And eventually, at hospitals, at private clinics, whatever, you would have a treasurer, which is basically optimizing processes together with the CEO and CEO. And I think that data, it's extremely unproductive and sad that we don't respect people and that we don't include people, right? It's not good. It's not good for productivity, and it's certainly not good for the soul of anyone. And I think that data can actually force a lot of awareness into the system because, and whatever that's in the one side and the other side, it doesn't really matter, but that is empowering the people, and I think that 98% of the people actually want to create a better and more inclusive society. There's a few people that don't, which is sad, but if we get the data to support that, I think that will be extremely powerful.
Thank you. Thank you so much. Jana, do you want to say something?
I fully agree, and I believe on this part, taking, first of all, ensuring the proper data collection and quality, and then that we follow privacy, then we can really exploit this for good.
Great. Thank you so much. I'm sorry we don't have time for more questions, but you can keep them for the next panel, which is about health and safety in the public space. And I would like to give the floor to my co-founder, Penelope Theodorakakou. No, Mariana Skilakaki. I'm sorry about that. Surprise.